Great. Thanks, Ashley. And again, thanks for all our sponsors. Thanks for everyone for joining us tonight. This is going to be a fantastic night. This is the first one of our new format, our new journal club format. We're going to start asking some speakers to come that are surgeons or physicians, friends of ours, to come join us over the next, hopefully we plan for at least the next year, maybe the next 12 journal clubs. So our first one, we're kicking it off with a great one. And we have Dr. Byrd with us. Dr. Byrd, thank you so much for joining us tonight. It's such a pleasure having you here. We really appreciate, we know you're like so busy, and we really appreciate you giving up your time for us tonight.
Well, I've been looking forward to this.
Bill, do you want to introduce yourself real quick before we throw it to Dr. Byrd to start?
Hey, everybody. I'm Phil Page out of Baton Rouge, Louisiana at Fran U. How many of these have we done now? Is this 12 or something?
This is 15.
15.
Number 15.
It feels like a month since I've seen you guys.
I know.
So I'm very happy. Dr. Byrd, great to see you again. You too, Ashley. Everything you do, appreciate it. And Rob, I'll let you take it over.
Okay, well, we're going to start.
One last thing
I
have to say. Dr. Byrd is going to do a little presentation. I'll let Rob lead into that. But while he's doing that, if you guys think of questions, please put them in the Q&A. I will monitor that through his talk. We won't interrupt him, but at the end, he's going to leave plenty of time for us to pick his brain and answer questions for us. So please put him in there, and I'll be watching that for you guys.
Yeah, we were talking, Ashley and I were talking before the start of this. We have an article that we're going to discuss, but if we happen to fill up the time talking to Dr. Byrd about all kinds of things, we may just do that and skip the talk, or not skip the talk, but skip the article. So I think he's going to be pretty stimulating for all of us. So Dr. Byrd, welcome. Can you tell everyone, if there happens to be someone on here, we have 101 participants right now. If there happens to be someone that doesn't know who you are, do you mind introducing yourself? And you can go ahead and start your talk if you'd like. We appreciate it.
Absolutely. I work for Ashley Campbell here in Nashville at the Nashville Hip Institute at TOA. And actually, we work together, and she and I would both tell you we've got a team here, and each of them are essential elements to what we do. And I like to tell people, I think I'm an important part as a surgeon, but I'm just a part, and that allows us to do what we do. But I'm an orthopedic surgeon here in Nashville, and I get credit for being one of the senior people in hip arthroscopy only because I stumbled across it in 1990, and not because I had any great design. So if I appear to distance myself from anybody else, it's just simply the blessings that have come my way.
That's great. That's fantastic. Well, we know you have a talk for us today. I'm not 100% sure what the title was, but if you want, you can share your screen and start your talk for us. I think I've actually heard this before, or at least something like this before from you before, and I think everyone's going to really enjoy it.
Probably some variation. I'll see if I can pull this up. Am I up there where you can see it?
Yep, we're good to go.
All righty, let me get this thing going. Turn the sound off on my phone there. And the topic I sort of picked was hip disorders in elite athletes, a few lessons learned. And when I said I was looking forward to this, that wasn't just idle chatter, because it's nice to talk to a group where their questions don't center around how do you bill for this and which widget do you use usually. And that's where I'm going to paint with a pretty broad brush and not trying to delve into too much minutia. But hopefully there's some things here and that may be applicable to the folks that are listening. And since you do get credits for this, my disclosures are available. I am a consultant and receive research support from Smith & Nephew Endoscopy. And again, this is about a few lessons learned, especially with elite athletes. And to quote Mark Twain, experience is the thing that tells me I've made this mistake before. Well, on that front, I've got lots of experience. But also, my father's chief of surgery was quoted saying to one of the residents, he said, "Son, you don't have to learn all the complications for yourself. You can read about a few of them." Well, there's lots of things that we can teach you, and mistakes and potholes that you can avoid, that you don't have to step in them yourself. Now, a famous physician said that he who desires to practice surgery must go to war. And that was actually Hippocrates more than 2,000 years ago, and that's still applicable today. And I think there are generally some parallels between what happens in combat and what happens in combat on the playing field as well. And somebody said, and I don't know who this was, there's no better clinical laboratory than the fields of athletic competition. And that's true, because really it's where there's so much as we're trying to be as innovative as possible to take the best care that we can of our athletes and allow them to do what their heart desires, which is to compete. Now, in 1994, we published our technique on the supine position for hip arthroscopy, which seems to have been adopted pretty much around the world. But also in 94, that was the year I did my first bona fide athlete, a Division I basketball player from the state of Kentucky, who got undercut on the basketball court his sophomore year. In February, landed on his greater trochanter, had groin pain, made it through the season. They made it through the Sweet 16, but by a month before his junior season, he still got left hip pain, and he had 3 MRIs diagnosed as atypical AVN. But with his mechanical symptoms, and his only problem was he couldn't dunk. And a 6'7" basketball player who can't dunk isn't much use to his team. So a month before his junior year, we went in. I remember I was sweating bullets because his trainer's looking over my shoulder. I don't know what we're going to find, but he had this unstable articular fragment off the medial side of his femoral head, which we excised a month before his junior year. And that year he was the league MVP and league leading scorer, which is much more of a credit to his ability than to mine. He went on to a successful NBA career that was ended by a foot injury, but not because of his hip. Now, in 1997, I was invited to a university that they asked me to come there to operate specifically on one of their athletes, and said, well, if you're here operating, why don't you give grand rounds? So I gave grand rounds on hip arthroscopy. And I remember when I got done, the chairman stood up and proceeded to give me his thoughts on hip arthroscopy. He said it's a triumph of technique over reason, and there's no place for it. I remember kind of sputtering and go, I don't know, we've got some things that have worked. It hadn't all worked. We're just feeling our way through. But sometimes it takes a while to get a sense of vindication. But I remember 5 years later, I got a little satisfaction when the athlete I'd operated on ended up being the first African-American to win a gold medal in the Winter Olympics. So sometimes it takes a while for things to come around. Now, 1997 was also the year that the Houston Oilers moved to Nashville. And for the first couple of years, they were the Tennessee Oilers, and somehow ended up being their team doc. And I remember during training camp that first year, sure enough, one of our offensive linemen developed left hip pain. We injected his joint under fluoroscopy, made it through the season, got to the end of the season, his hip still bothering him. And I'm looking at having to scope his hip, and I'm thinking, great. How is it that the only Yahoo in the league who scopes hips just happens to have somebody on his team with that needs a hip scope? And I thought, man, this is going to be a short NFL career for me. But sort of we bit the bullet, went in the end of the season, found all these fragments, a lot of articular damage, things that would bode poorly for a successful outcome. But he went on to be a starter, and 20-something years later, he's had both knees replaced, but he's still kind of kicking along with his natural hip. And I later presented that at the NFL Team Physicians Society meeting. And I remember one of the trainers, Don Mosley, who just retired last year, came with the team from Houston. And he goes, I remember a couple of these guys back in Houston had these hip problems that never got better. I mean, these groin problems that never got better. So I wonder if some of them might have had a hip problem. And it wasn't until years later it finally registered with me that it wasn't that I was the only Yahoo in the league scoping hips that had a player with a hip problem. There are a lot of players in the league with hip problems. We just weren't any good at diagnosing. Now, in 2001, we published the first scientific article on hip arthroscopy in athletes. The mean improvement was 35 points on a 100-point scale, with 93% showing demonstrable improvement. And these were all simple debridement procedures, so they showed the greatest improvement in the first month, pretty well peaked by 3 months, and those results were pretty well maintained for 5 years out. Well, as somebody once said, nothing ruins good results like follow-up. When we looked at these athletes at 10 years, sure enough, the median improvement was 45 points, 87% got back to their sport, but a third of these ended up getting converted to a hip replacement in an average of 6 years. So it was after 5 years that the wheels were starting to fall off and we realized our results weren't that durable. Well, fortunately, Professor Gons came along and taught us about femoral acetabular impingement as an underlying etiology. And now we finally had something we could address to try to alter the natural history. And really, for most sports-related things, FAI is really the 600-pound gorilla in the room. At the other end of the spectrum is dysplasia, and in sports and performance activities where flexibility is a premium, that's where we see issues with dysplasia, because dysplasia is advantageous up until the point that things start to break down. And the big three are dancers, gymnasts, and figure skaters. But I would add as a significant fourth in that, wrestlers. We see a lot of problems with dysplasia in wrestlers because they have to be flexible. Now, we've published our technique on arthroscopic intervention with FAI. This is our first 200 athletes, looking at all athletes, and I really thought these would be the worst results ever published, but that's not necessarily true, because I think back then we were vetting them so carefully, and as we've gotten more confident in the procedures that we could perform and our indications have expanded, I wouldn't say that our results have necessarily improved, but back then in that first 200 athletes, 25% of them underwent microfracture, and that's a huge number. That tells us that we were intervening very late in the disease process, and we're pushing to try to intervene earlier without operating on asymptomatic individuals. And what we found is that about 90% return to their sport. It was 95% at the professional level, 85% at the collegiate level. And there's a couple of important messages in here. First of all, I think we know we're not doing a better operation on our professional athletes than the collegiate athletes, but there's a lot that goes into our surgical successes beyond simply what happens in the operating room, namely the intensity and the quality of the rehab resources available. But also we know that as clinicians, there's a lot that goes into our care of patients beyond simply what we can accomplish as mortal human beings. We had a handful of complications, none of which compromised a good result. We had 1 or 0.5% that was converted to hip replacement. So I feel like that means we were picking our patients carefully. We weren't operating on people who just needed hip replacements, but we had 2% that underwent repeat arthroscopy. So we're doing an imperfect job with our procedures. But trust me, in today's world, our revision rate is much higher than this, because as we're doing more complex procedures, tackling more challenging problems, our revision rate is a lot higher than it was back then. Now, in 2002, at the AOSSM meeting in Orlando, Frank Jobe was the Kennedy lecturer, and he spoke about sports medicine. And one of the things he spoke about was that Supreme Court Justice Potter Stewart, who had to weigh in on a case of trying to define pornography and obscenity. And he struggled to try to define this. And ultimately what he said, I can't define it, but I know it when I see it. Well, I think that sort of applies to sports medicine. So I guess you could lump sports medicine with pornography and obscenity. But to me, sports medicine is almost more of a philosophy. It's a comprehensive team approach in the management of athletic and fitness-related injuries and illnesses, with an emphasis on injury prevention and facilitating and optimizing recovery. Recovery isn't always getting them back to perfect, or not even getting them back to their sport, but at least trying to make them as good as we can possibly make them. And there's really a science and an art form to simply practicing good medicine. That's really all we're doing. Now, John Chapman was the Dean of Medicine at Vanderbilt University School of Medicine. He was the longest tenured dean. And he used to say that the most important skill for a clinician scientist, you kind of wonder what should that be? Well, to him, the most important skill was communication, because it didn't matter your depth of knowledge or your diagnostic acumen. If you couldn't communicate it, it was absolutely wasted. And that's where, to me, Dr. Andrews is the master of communication, because many physicians, they become known as the team's doctor, or they become known as the agent's doctor, and nothing drives the athletic training staff crazy like having their athletes going off somewhere else and getting care, and then getting kind of cryptic messages back on what's going on with them. And that's where Dr. Andrews is the master. He makes sure everybody hears the exact same message. And my father, who's a general surgeon that dedicated his career to fighting cancer, a much more admirable pursuit than anything I would ever do. I remember him saying that if you never lie, you never have to remember what you said. It ought to always come out kind of the same, or in a more selfish sense, the truth is a protection against a poor memory, and mine just gets worse by the day. Now, as far as some unique considerations of elite athletes, certainly we always have, well, there are exceptions that I make in how I treat elite athletes. And I think we all know that you're treading on thin ice. You need to be careful anytime you're making exceptions to whatever you perceive as the normal standard of care. But exceptions are the reality, because these athletes have a lot more time and resources to dedicate to their recovery. They're highly motivated. That can make us look good. And by definition, they have a high pain tolerance, which is both good and detrimental to them. And I don't care, the wimpiest guy that's on your team, they don't give in to pain that easily in order to get to even be on the team. So there's always sort of a congenital insensitivity to pain. Now, this is a perfect example of do as I say and not as I do. This is a professional wrestler. At this point in his career, he only wrestles once a year during WrestleMania. They give him a portion of the gate receipts just to show up, and he's trying to train to get ready for WrestleMania, and he can't because of his left hip, but not really his hip. He doesn't have left hip pain. What he has is recurrent groin and SI joint symptoms where he's compensating for the stiff hip. And he's asking me, do you think you can take these spurs out, maybe give me a little better motion? I said, listen, we may swap out a painless stiff hip for a painful hip with better motion. He said, well, I can't train the way it is, so why don't we try? This is a CT scan. We went in arthroscopically, took out some of the fragments, chiseled out the osteophytes around the rim of his acetabulum, reshaped and recontoured the rim. There was no labrum, it was all ossified, took down the cam lesion. You can see a big herniation pit that we curetted out, gave him better motion. There's some of the fragments that we took out. And actually, he did pretty well for a couple of years. He was happy with his hip. He's able to train and get ready for WrestleMania. After a few years, it finally gave out, and he got a resurfacing procedure. But then a few years later, when his right hip went bad, when faced with the same choices between trying to take the spurs out versus an arthroplasty, he opted for the same thing. Hey, let's take the spurs out, buy me a couple more years, which we did, and eventually had that side done. Not the sort of case I'd be proud to show at any meeting or if I was giving my boards. Now, and this was well over 10 years ago. One of our offensive linemen had multiple lateral degenerative disc changes in his thoracic spine. He had back pain. He's able to play, but he was saying, but is it going to get worse if I keep playing? We sent him over to Craig Brigham, who was one of the outstanding spine surgeons in the NFL, who tragically passed away at a fairly young age. But I remember Craig talking to him and said, remember, you don't play football for your health. It's kind of an attritional sport like most sports are in some fashion or another, because if you're successful, you're pushing your body to the limits in some fashion. So we do have to keep in mind that athletes have a finite life of their competitive athletic career. It's often a quickly closing window in which they have an opportunity to generate substantial income. And you may choose to be short-sighted for economic reasons, but it's important that the athlete is part of that decision-making process and aware of where you're talking about short-term goals for performing and competing versus the consequences that can have long-term. And this isn't just professional and elite athletes, certainly the scholarship athletes, if it's a chance to get their education. And those athletes, I especially emphasize to them, listen, make sure and get your education, because a professional career may not be in your future. And it actually spills over into the high school level, because you may have a high school kid whose only opportunity to get a college education is based on his athletic ability. Then you throw in these NIL rules with NCAA, and that kind of blows the roof off of all of this stuff. Because I really emphasize, and Ashley will back me up on this, that by the time an athlete lands on my doorstep, it's unlikely that their hip's ever going to be returned to truly normal. There's a lot of things we can do to diminish symptoms and improve the longevity of the joint, but you can't ever really make it a normal native hip again. And I really use what Dr. Andrews used to say with these kids that tear their ACL. He goes, "You're going to be normal." He says, "It's like a antique vase that's been dropped and broken. You can put it back together and it looks good and it functions well, but it's not ever the same antique vase." One of the things I emphasize is you really don't want to be in a hurry to operate. There's nothing worse than matching an enthusiastic surgeon with an enthusiastic patient as far as a recipe for disaster. You say, well, wait a second, there's a lot of studies that show that there are poorer results of arthroscopic surgery the longer the duration of symptoms. But does that mean you really need to be operating on them right away? And the answer is not really, but keep in perspective that regardless of the recency or the suddenness of the onset of symptoms, FAI in particular is the culmination of the cumulative effect of a disorder that's been present since childhood. The problem's been developing long before they first become symptomatic, and they've been compensating long before the joint first proves to be a problem. The compensatory problems actually may cloud and obscure the underlying joint disorder, and that's where the rehab process can assess and address the compensatory problems, can reduce symptoms, improve performance, and oftentimes regain their ability to compensate. Now, in general, once somebody shows up and they're symptomatic from FAI, it's unlikely that somehow it's just going to completely get better and go away. And sometimes you'll see people where it's evident they're in trouble and that surgery is really the most definitive course. And there's not necessarily a reason to just kind of keep kicking that can down the road further if that's the direction to go. But it definitely doesn't mean that their only choices are suck it up or do an operation. There are various strategies to modulate those symptoms. And I tell people the symptoms are stable, then I think a non-operative treatment strategy is appropriate. If the symptoms are getting worse despite these conservative measures, then I think it's better to be proactive and address it with surgical intervention rather than simply wait and see how much worse it gets. Now, I think it's important to, and this is true for everybody on this meeting, that to emphasize that just because you're not recommending surgery doesn't mean that it's not a serious problem. The number one complaint of athletes who come to me because they're at a point they need surgery is, you know, look, you're telling me I need surgery and all those other people did were want to try therapy and injections. Well, the reason you're here is because therapy and injections have failed. But so it's important to not try to downplay that it's not that big a deal. I'm not opposed to judicious use of intra-articular corticosteroid injections. The strategy we use the most often is really a two-pronged attack where we're injecting the joint to get the joint quieted down so that supervised physical therapy can be more effective. Trying to correct those compensatory problems may regain their ability to compensate, or at the very least, put them in a better position for surgery to potentially be successful. Also looking at it as a standpoint, well, compared to surgery, maybe at least trying a one-time injection doesn't sound like a bad alternative. Now, I think a one-time injection is not going to compromise the long-term outlook for any of these individuals, but a multitude of injections is ill-advised because then you're just treating the symptoms, allowing them to go out and cause more damage without knowing it. Now, what about orthobiologics? And I think it's important to keep in mind that the science is incomplete, and there are a lot of folks purporting this for all kinds of claims. Many of those are well-intentioned, but some are a little more nefarious. And you just got these young folks with a lot of loose money in their pockets, and there's plenty of folks out there that are trying to separate them from some of that money. And I think that that's where it's so important to know your athletes. And to me, that's the difference between a team physician and a specialist. And I like to use the analogy of flight surgeons. Flight surgeons aren't necessarily surgeons, but they're physicians who are embedded with the flight teams. They live with them day in and day out, eat with them, they get to know them, where oftentimes they can detect problems with the pilots before the pilots even realize there's an issue going on. And I can tell you, our head athletic trainer, Todd Torselli, he can watch these athletes on the field. He sees movement problems, and he can pick up on problems with the athlete before they ever even show up to complain that something's amiss. Now, with PRP and stem cells or anything else you want to mention, you have to think about what do these things do? Well, they can do one of two things. They can potentiate healing, or they can modulate the symptoms of osteoarthritis. And so much of what we deal with revolves around FAI, and FAI is a structural problem, and all the injections in the world aren't going to modulate a structural problem. I also think it's wise to be temperate in your enthusiasm for these biological treatment strategies, especially in the hip. The hip responds differently than other joints. This is just an NFL defensive tackle, comes to me fresh off failure of $50,000 worth of injections that didn't solve his problem. So he comes to me for surgery. We put the brakes on because I just didn't want to risk getting an infection, scoping his hip on top of all these injections. So we stalled him. Finally ended up operating on his hip. 7 or 8 weeks later, he comes back to see me. You know, your hip's kind of stiff. Well, let's get an x-ray. And he had all this heterotopic ossification. It's convenient for me as a surgeon to blame it on all the stuff he'd had injected in and around his hip, but I've never seen this magnitude of HO this quickly after an arthroscopic procedure. Now, lastly, I'll just leave you with, to me, evaluating complex hip problems without benefit of ultrasound is like practicing cardiology without a stethoscope. It's the single greatest adjunct to your history and your physical examination. Now, why is that? Because I tell people I can diagnose a dislocated shoulder or a torn ACL drinking a beer, watching a football game on TV. I don't need ultrasound to figure these things out. But really with the hip, all hip problems are complex. They've got coexistent pathology, compensatory disorders, other coincidental things. And I tell people it's a good day when I see somebody who has an isolated intra-articular hip problem. Usually they've got a lot of other things going on or other things that can mimic these hip disorders. Now, going back to that 2001 article on hip arthroscopy in athletes, we found that 60% of these athletes were treated for an average of 7 months before they began to recognize that the hip joint might be the source of their symptoms. And in case you think that's just old historical data, more recently, John Clohissy over at WashU showed that young adults with non-arthritic hip disorders, especially FAI, see an average of 4.2 healthcare providers before a diagnosis is reached. So these things can tend to be very elusive. And with ultrasonography, I think it provides a structural perspective, especially in a dynamic fashion that MRIs don't give you. And for the young clinicians, I really tell you, ultrasound is a great learning tool. There's so much you can learn about what's going on around the hip. We use ultrasound guided injections, both for diagnostic and potentially therapeutic purposes. Now, one of the things that's important, if you're going to use it as a diagnostic test from the anesthetic, it's critical that the athlete be able to generate the pain before putting the anesthetic in there so you can retest them afterwards. And a lot of times with me moving somebody's hip around in the office, I'm not generating anywhere near the type of force they do in the field. And that's where a lot of times we'll send them to the physical therapy department, let the therapist really put them through their paces, make sure we can generate the pain so that when we inject the anesthetic, we can differentiate how much the joint or whatever area may be the source of their pain, because there may be various areas that you're injecting. We'll inject them, reassess them, record that, because you can't ask the athlete a month later which injection helped the most. They can't remember. Now, not everybody has one of these, and I'm not talking about the ultrasound machine, but Beth Bardowski, our nurse practitioner who helps to tell Ashley and me what to do around here. Beth has more experience with ultrasound guided injections than anybody in the history of the world. This is just one of her patients where she's drawing fluid off his hip before a big performance. So she draws the fluid off, gets his hip feeling better before he's got to go to work. Then here, Beth gets a good photobomb opportunity as he's yucking it up with his boss, and there's Beth and Kay in the background. And to paraphrase Carl Malden in the old American Express Traveler's Checks ads, ultrasound, don't leave home without it. Well, with that, I'll stop and happy to entertain questions or whatever y'all would like me to do.
Wow. Wow. Thank you so much, Dr. Byrd. Yeah, that was fantastic. There's so many pearls within that talk. It's just unbelievable. I really enjoyed it. What do you think, Phil?
Yeah, I love listening to you every time, Dr. Byrd. and your lectures, you like Rob said, we've heard a little bit of that every time, but you always bring out something new. Man, that was so awesome, Dr. Byrd. Thank you so much.
I got to, it actually keeps me on my toes.
Well, Casey was texting me. I was talking right along with you until you threw out the obscenity slide, and then I got thrown off course. That was a new one. We got a couple questions, or one question. Our buddy Amir is here. He's actually in the States, Dr. Byrd.
Oh, really? I was going to say, what time is it out there?
Yeah, no, he's actually in New York with one of his tennis player. For the US Open. And he said, thank you, Dr. Byrd, for an excellent presentation. In Australia, we have the issue that physiotherapists believe that physio is as good as surgery for FAI syndrome. I certainly do not agree with that. What would you recommend with regards to total time to try physical therapy before you refer to an orthopedic specialist? If you're coming to the US Open, please let me know. Regards, Amir.
and again, to me, once somebody gets into trouble with their hip from damage associated with the FAI, there's no really reversing the damage. But there's a lot of things you can do to modulate the symptoms. And I've seen people who've had symptoms literally for years, and then maybe it eventually gets to the point to talk about surgery, and you go in arthroscopically, and yes, they've got some labral damage and some articular damage, but there's nothing about it where I go, oh, we should have gotten to this several years ago. So I don't think there's a sense of urgency. And usually the best way people respond to conservative treatment in the long run is they just modulate their activities, which is a very reasonable direction to take. But beyond that, that's where there are so many things we can do from a conservative standpoint. So again, I struggle, and I'm a surgeon, but I struggle with the idea that these can be treated just as well non-operatively.
When I saw that question, Doc, I immediately went to my thoughts of primary and secondary shoulder impingement. And that's what I think a lot of people think is when you hear the word impingement and you apply to the hip, you're like, well, secondary impingement isn't a surgical case, it's a rehab case. Do you ever think that there is this new thing of micro instability? Are there areas of FAR that may not be as structural as they are functional as we see in the shoulder?
Well, FAI is a functional problem. And that's where with pelvic stabilization, you can literally reduce the forces across the hip joint. So there's a lot of those things where there's a portion of these, if their FAI problem is more dynamic and less static, you can treat the dynamic part. And that's really that's what you can treat the root cause. That's not, oh, we're just treating the compensatory problem. But so I think that's where some of these people can genuinely respond to conservative treatment. But across the board, we just, again, and I think starting with a conservative program is always appropriate. And then how long do you give it? I always tell people that's like asking somebody how much a putt's going to break. How much the putt's going to break depends on how hard you hit it. Well, how long you give it depends on how they're responding. If they're showing positive response, give it as much time as you need to. But if they're 6 or 8 weeks into it and they're complying and you're doing all, and they're not getting anywhere, you don't have to arbitrarily kick the can down the road for, say, 6 months. So I don't think there's an arbitrary amount of time to give it. And the way I view FAI is it's like the front end of your car being a little out of alignment. It leads to uneven tread wear. And then over time, as you start to flip off the tread, that's when you start to feel it. And how quickly that occurs depends on your driving habits. That's why we don't see young people get into trouble with FAI unless they're involved in sports. When we looked at our data, 60-something% of our overall population were involved in sports, but it's about 96% in the teenagers. So I mean, and that's where the problem's not about the sport, it's about the structure of their hip. But anyway, that's where when they get into trouble, you can put new tires on their front end, but if you don't correct the alignment, they're just going to wear out the new tires.
Love it.
Yeah, great. Dr. Byrd, you said you were telling us that you, when in your talk, you said I think it was actually before your talk, you said you just happened across hip arthroscopy and working on the hip. So what really happened? What motivated you to really fall in love with the hip and start treating really specifically it rather than other joints?
Well, there are really the two most important cases in my career, where the first one I ever did was just a 16-year-old kid with loose bodies in his hip, and one of my partners was going to do an arthrotomy, open it up and take out the loose bodies, and asked me, well, what do you think about doing something arthroscopically? And I thought, well, I never heard of such a thing, but I said, hey, as long as we don't do something dumb like cut the femoral nerve, we'll try. And when it doesn't work, you can just flip them over and do your arthrotomy. Now, and the bottom line is I basically use the skills that Dr. Andrews, as I tell people, Dr. Andrews didn't teach me how to do hip arthroscopy, but he instilled in me the fundamentals on how to take loose bodies out of shoulders and knees and elbows that kind of allowed me to figure out how to do it for the hip, and it worked. And I will say that, and Ashley knows this because she's nudged me in the ribs all the time, that I'm a creature of habit and like to do everything the exact same way forever and never change anything. So if there's anything that seems innovative that I've done, it wasn't because, hey, I got this crazy idea, let's do something new. It's only because the direction we were taking seemed better than the more conventional alternatives available to me. For this guy, I just thought, well, compared to an arthrotomy, dislocating his hip, why don't we try it? And it probably won't work, but we'll try not to damage anything and try not to harm the patient. So after a couple of years, the only thing I knew about was loose bodies. That's the only thing we knew about in the hip. So we did a couple of loose body about once a year. And there's a really important message here. But one of the physical therapists who'd rehabbed these came to me and said, I've rehabbed these people with loose bodies in their hip. He goes, I think my brother's got loose bodies in his hip. He'd been in a motorcycle accident 14 years before, injured his hip. He used to work framing houses, had to quit work because he never knew when his hip was going to give out on him. And after 14, all his studies were normal. And I thought, well, after 14 years of symptoms, maybe it's not too soon to take a look. Well, maybe he got some sort of radiolucent loose body that we just can't see on these images. So, and to me, it wasn't like, well, hey, he's had symptoms for 3 months. Let's take, after 14 years, there was really, and to be honest with you, I figured it's going to be a normal hip scope. So we filmed it, and we looked at his hip, and he had a bucket handle tear of his labrum flipped up inside the joint, which we excised. And after 14 years, his pain was gone. And things have to hit me like a ton of bricks. That's when a little light went off. Said, there's other things inside the hip besides loose bodies that we just don't know about. And that kind of set me on this track. Now, the important message there is it was a physical therapist that dialed me in that this is what's going on, because the point I emphasize to people is the therapists are light years ahead of orthopedic surgeons in evaluating the hip, because before the arthroscope, as a surgeon, if they didn't need a hip replacement or have AVN, we quickly ran out of interest in what to do. But the therapists aren't looking for surgery. They're just trying to figure out how to help the patients. And that's where the therapists are light years ahead of us. And the other point I would make is this is not there are a lot of people who had done hip arthroscopy before I stumbled into this. But what happened for a lot of them is it just didn't work. They had poor results. And it ain't because I was some genius on who to pick for the operation. I was just very blessed that all of a sudden these people showed up. The first few I was able to help. So I didn't get discouraged and quit like the other smart people who did. And that ain't a very good idea. So they just kind of quit doing it.
You just didn't give up.
Those cases worked.
Yeah, you didn't give up. The others maybe did.
Well, they gave up for good reasons because they saw harm being done. And I just stumbled into these things.
Yeah, great story. Phil, do you got any questions? I got more. I can ask more if you don't.
No, I'm great. I'm just love listening to you, Dr. Byrd. Keep love this.
Well, I love listening to me too. So Ashley's like rolling her eyes like, there you go.
I will tell you, Doc, what you said, which is what I really like, is that you looked at a problem that hadn't been addressed before in the method of doing hip arthroscopy, but knowing hips, shoulders and knees, that it could be applied to that. And I think a lot of people are scared to try things that aren't true, and trusted. But if you can just apply what you know and go in, and like you said, in certain situations, like you were talking about Ashley, we had, you go to a restaurant, you're going to order the same thing. Well, the only time you don't is if something's off the menu and you have to order something else. How would you know that it was great? It's only in those situations that you're put into that you actually go, oh, this actually did work. So don't be afraid to try things that are new. Get out of your comfort zone a little bit when things start to make sense. And I think that would help us go a long way in our therapies.
Look at Phil throwing out some great advice.
Sorry.
Wow.
And
No,
along
it's
that
awesome,
same
Phil. That was
line-
fantastic.
Along that same line, again, anything I've done that seemed to be innovative, I feel like I'd get criticized for it, but I could sit before my boards and at least I had good reasoning for why we did it. That it just seemed better than other choices. And there's bunches of examples through the years, where we started doing endoscopic piriformis releases, things, didn't just decide to start doing it one day. That well beyond sort of getting into lengthy dissertation here.
Dr. Byrd, go ahead, Phil. I'm just go on the questions.
That quote that you had of that doctor that said when you started doing the scoping, like it's great for technique, but it's not going to last.
Uh-huh.
I mean, that's what this is all about. There's so many naysayers out there that go like, oh, it's great that you did something just because you could. Does it mean it's going to be great? Well, no one's going to have something great until you actually do it. And you do those types of things like a piriformis release. I mean, come on, this is awesome. You're groundbreaking in this stuff in a great area that I think the hip is exploding right now because of the stuff.
It's been for a while. Yeah.
And you just went out and you are the pioneer in the hip. And it's just great for all of the sports therapists that are out here on this call that just go like, thank you, Dr. Byrd, for, supporting us and for waking up everyone about the hip. I'm a newborn guy when it comes to hip. Thank you so much.
Me too. I mean, we're all just barely, I may be a little further up the curve than some, but I'm like here and everybody else is here and this is where we're heading is up here.
Yeah. Great. Dr. Byrd, we have another question that someone sent in. It says, thanks, Dr. Byrd. Are you aware of any methods or technology on the horizon to detect CAM lesions before they develop?
Not aware of anything to detect them before they develop. There's a lot of, it's easy to understand how the joint gets damaged from a CAM lesion. But then the question is it's especially why athletes, young kids are all in athletics, why the CAM gives them trouble then. Otherwise, if they weren't athletic, it might not bother them for another 10 years. But is there anything that sort of makes the CAM lesion form? And there's a little soft evidence out there where looking at some sports like soccer or hockey, where maybe they look at a population playing those sports and a population that didn't, and maybe there's a higher incidence of CAM in that group that develops. But we're still just barely scratching the surface, because certainly the key here, like anything, is prevention. Because again, like I say, once they land on my doorstep, the cat's out of the bag. But and we're working on that in every fashion. There's not a lot, anything from a preventative standpoint, that we're really just scratching the surface. And then you also get into, well, how aggressive do you want to be from a preventative standpoint for something? Because there's also lots of people with all kinds of x-ray findings of impingement. We've looked at these master's level athletes in their 70s and 80s performing at a high level with all kinds of x-ray changes. So, and that's where, as I tell people, the hip joint problems we see are a perfect storm. It's enough things coming together just wrong to get the athlete into trouble. And FAI is just part of it, because how are some people lifelong compensators? And that's where we want to understand all these different, because figure out the ones that we can influence.
That's great. I have a question for you about your team. You always brag about what a great team you have at the Nashville Hip Institute. Can you talk a little bit more to us about, about trust and role playing and playing your role within your team and how that affects outcomes with hip patients?
Well, and I guess I hate to hear I'm bragging, but I guess I just, I'm so blessed.
I mean bragging in a good way, not in a bad way.
Because when somebody talks to me about how great Ashley is or other team members, and my tendency is, well, I agree with you. And I say that not because they work with me. I'm just very fortunate that we've got such a great nucleus of folks. And I think the key is teamwork and a lot of give and take. I promise you, I learned tons more from Ashley than she learns from me. I can tell good stories and I've got more gray hair and all that kind of stuff. But we all learn from each other. Beth, the master of ultrasound, Kay Jones, my nurse, who we just celebrated her 30th year not too long ago. And I like to tell this story. Well, a couple of things that, I mean, I'm sure a lot of y'all have heard of the C sign. Everybody, and that they tend to know that I'm the one who described the C sign. Well, actually, I'm not the one who described the C sign. It was my nurse, Kay Jones, who came to him one day and said, you know, have you ever noticed these people with hip problems, they kind of cup their hand above the greater trochanter, and it looks like they're describing a laterally based problem, but they're really describing interior hip pain. And that's where she has an incredible power of observation. And there's a lot of brilliant folks out there who can't see things that are right in front of them. But also she doesn't know how to, her skills are not examining patients. Her skill, but she can learn more because she spent years talking to patients over the phone. She can diagnose more things over the phone from the history alone. And I use the analogy of when somebody loses one sense, like if they don't have sense of sight, then their sense of hearing is really amplified, where her history taking skills are off the charts.
That's great. That's great. Tell me, Dr. Byrd, what are some of the, if you think of therapists and, you know, not any one particular therapist in general, but what kind of therapy mistakes do you feel therapists make when treating hip patients? I mean, what are like some of the things that like you would wish they wouldn't do that therapists maybe do?
Well, and that's a great question for a room full of orthopedic surgeons, because I can sound really smart answering that question. But I promise you, I'm just a parrot recounting what Ashley has taught me through the years. And
so we should have asked Ashley this.
And also back to the question about kind of the, you know, what is it that makes our team? I'm very interested in Ashley's perspective because I've got my opinion, but Ashley's got, I would like Ashley to address both those questions.
Let's hear it, Ash. You're putting you on the spot. Yeah.
I guess I'll go in reverse as far as I kind of my pearls and pitfalls talk when I talk about people treating these hip patients. And honestly, if we're talking about hip arthroscopy and treating people post-op, I'd say it's pretty much two ends of the spectrum. Either they're doing too much or they're not doing enough. And it's usually pretty simple. And that's why every time they come back for a follow-up with Dr. Byrd, they see us in the therapy department and we kind of see how things are going. And we can come up with a plan to fix the problem about 95% of the time. So most of the time, if they walk in and they're just, you know, I'm so worried, I think I retore my labrum, blah, blah, blah. Sorry, I have a dog in training right now. So we get them on the table. We're like, oh no, you know, you need more inferior glides and you need a little bit of deep rotator activation. And let me show you. And we do it with them. All of a sudden we can move their hip around. They don't have any pain. They're like, oh, wow, I'm fine. I'm going to be okay. And we're like, yeah, no problem. We'll just let your therapist know a few things to make some tweaks. And a lot of times, honestly, it's more times than not, I think therapists that don't see a lot of hip arthroscopy are worried that they're going to do harm by being a little bit more aggressive, whether that's with manual therapy or exercise or things of that nature. So we tend to see people just kind of hanging back and kind of tippy-toeing around it. But that's what we're there for. And I think that is what makes our setup and our team great is, you know, every piece of the puzzle knows who to go to in any one scenario. So if Kay's getting phone calls about something and she listens to it, she's like, your therapist needs to talk to our therapist and we can get it straightened out, you know? Or, you know, I'm talking to a patient, I'm like, you know what? I really think this patient needs an injection. Like I can go to Dr. Byrd, explain, he has the trust in me to be like, yep, let's do that. Get with Beth. We do it. And we can just make that all happen in a very smooth fashion by all being in one spot. So there's a lot of things that make our team great, but I would say, you know, our ability to just kind of know what the patient needs and get them with the right person in our office that can make that happen is is probably the biggest thing.
A couple of comments building on that, and I say this all the time, that when the patients start asking me about the rehab parts, I'm quick. The therapists don't tell me how to do the surgery, and I don't tell them how to do the rehab.
Oh,
Let
that's
them kind
nice.
of weigh in on that. And along with that, I think you have to have a therapist that you're confident in. And you don't, we're very blessed to have a great team, but for most surgeons out there, you don't need a team of people. You just need one person who's interested. Because if they're interested, you can learn together, because nobody's got it all figured out. And I will say in my practice, I think roughly about 80% of the people who are having problems when they come back after surgery, at least 80% of the time, it's just an adjustment in their rehab. And that's why they'll see the therapist first, because then they come to see me and they're telling me about the problem they had that's already been kind of addressed, and they've got a plan. And I go, yeah, that sounds like a good plan to me. But if they see me first, and I'm like, I think maybe it's but it certainly takes a village.
I think that's
No
a
doubt.
good lesson on how, talking about part of the reason why we went to this format in Journal Club was to talk about this team of the therapist and the surgeon. And what you just described, I think is perfect for what we're trying to accomplish here, is how does that relationship work? And it comes with, obviously trusting someone who's interested, knowledgeable, experienced. But I like how you said, Doc, that they go to the therapist first and then they come to you. And I think that's really important, because it saves you a lot of time too, as a busy surgeon. So it's really important that Ashley sees these folks first. And then I love how you do, yep, I would do the same thing. Whatever Ashley says, I believe 100%. Yes.
And it's also best for the patients. I mean,
Exactly.
It saves me not only a volume of time, but the frustration that would be involved in a struggled conversation that I kind of think I know, but then I just send them to Ashley and her team, and they get it sorted out and figure out a plan.
And I'll just add one piece. I know we got a couple questions, maybe hit real quick before we and that is the other piece that really is beneficial to us being all together, is that when these patients come and they see all of us, we're all always saying the same thing. And the patient's like, that's the same thing Dr. Byrd said to me.
Yeah.
And
That's
vice
helpful.
versa. It's like, and now they've heard it 3, 4, 5 times in a day. They're like, okay, I'm starting to believe this. Like, you're all telling me.
You get some buy-in when you all have the same opinion and describe it the same way, don't you?
Especially with athletes, especially with the athletes.
Yeah.
Especially.
There's a question, what's your standpoint on ultrasound therapy? Does it help with FAI? And I'm assuming that question is about the use of ultrasound as a modality, not ultrasound as
That's
a
why I wasn't
diagnostic.
sure. Yeah, I wasn't sure about that one.
As a diagnostic tool, it's, like Dr. Byrd said, it's imperative that that's utilized. But as a therapy standpoint, I can tell you we don't have an ultrasound unit in our clinic from a modality standpoint. FAI, first of all, is a structural bony problem, so the use of ultrasound really wouldn't be indicated to benefit it. But we do have some other modalities that we utilize with some different types of laser therapy and focused shockwave that has been incredibly beneficial in some of the compensatory things that we see in these patients. And then the other question was, what's the average time for athletes to return to sport? Do you have testing in place to determine? And I can let Dr. Byrd talk on that. I can give my kind of normal spiel that I give to the athletes, but generally speaking, we give most athletes the conversation of, you're probably looking at about 6 months before you're going to be returning to sport. 4 to 6 months is kind of the window we give. And there's a lot of reasons why one person might go back on the earlier end of that, or someone else might go back on the latter end of that. And yes, we do have testing in place. And I think the difference in the hip that I've experienced compared to my previous life when I was seeing a lot of knees and shoulders is, the demands of the particular sport dictate the testing that we do. So we don't have like what I would call like a standard test that every person gets put through, but we do utilize a lot of variable ways to load the hip. And then we use the tracer system to test for things like reaction time, deceleration, acceleration, speed. We look for asymmetries, and that's probably the biggest thing we look for. And the biggest thing on returning these guys to sport, and no matter what age level, professional to youth, is just load management. So the biggest area where we see these go wrong when we start to return to sport is that there's poor load management. They feel great. They're 4 months post-op. They say, oh, doc said 4 to 6 months. I feel great. And they just go. Whereas with ACLs, because of just the nature of the knee and the sensations of instability and just the duration of the rehab, it's just a whole different ballgame. So our testing that we do is variable depending on the sport and the particular athlete, but it does happen. And the average return to sport is somewhere around the 6 months time for a primary arthroscopy. If we start getting into revisions and things of that nature, it might start
Different
getting
story. Yeah. Actually, did you see the question from our prior host, guest host, Lori Bogola, listening?
Yeah.
She said, have you tried blood flow restriction? I'm assuming for hip patients. It's supposed to strengthen the entire lower limb. Just curious.
Yeah, we do utilize blood flow restriction in our clinic. Most of the research that's been done is more particular to distal versus the proximal muscles, but there's plenty of evidence to show the systemic effects of blood flow restriction. So certainly we do utilize it, especially in people who are maybe a little bit slower to be able to tolerate more loading progressions, maybe because of some pain or some compensatory stuff that they've had going on for years leading up to this. So, but yes, we do utilize it. We don't have a particular protocol per se that it gets used on everyone at this stage, but we do use it in our clinic.
Great. Hey, Dr. Byrd, as we close here, we got just a couple more minutes. Can you tell us what kind of what's exciting for you about the future of hip surgery and seeing hip patients? What new exciting things, if there is anything coming around the corner?
Well, and I think the main thing that's exciting to me is kind of early on, there's a handful of us cowboys doing this stuff, and we could pretty much recite each other's talk. But now, and I really think it started with Brian Kelly at HSS. There's some really remarkable clinical scientists who have gotten involved in this. So there's some really brilliant folks out there: Shane No, Ashish Beatty, Chris Larson. I shouldn't mention any names because there's so many more, but that as these younger people that are really brilliant are getting involved, they're taking it to a whole new level. And that's what excites me. And it's one of those things that I've been very blessed with things I've been able to do. And my sense at this point, I just don't want to blow it. I want to be able to build on that myself and not just kind of waste it.
Yeah, that's great. That's fantastic. What do you think? What do you guys think, Ash? You want to stay on for just a couple more minutes and ask a couple more of these questions, or you want to call it good? Okay. So we have a couple more questions for you, Dr. Byrd. Here's one from Jonathan Romero. For patients who are less than 35 years old, you are recommended. I'm sorry, for those that are less than 35 years old and are recommended to get a THA, is it best to wait as long as possible or to go ahead and do the surgery? So in someone younger.
Yep. And that's sort of a philosophical question around hip replacements that that's what I'm going to give you a lot longer answer to this. But one of the things we found about with arthroscopic surgery, there's a lot of literature that says older patients don't do well and they shouldn't do it. But that's not true at all. We actually looked at our patients over the age of 60 with labor repairs compared to an 18 to 55 age group. And when we matched them for the severity of articular damage, the over 60s did just as well as the younger patients. It's not age, it's just the severity of the articular damage. And you see more articular damage, more arthritis in older patients. And that's where arthritis is bad, whether you're 65 or 35. And that's the one thing that arthroscopic surgery can't reverse. And you may have somebody who's, sometimes in a 35-year-old has got some modest arthritic changes. You might say, well, as young as you are, let's take a stab at it. We know the surgery is not going to be successful, but I think it's worth trying versus folding up the tents and getting a hip replacement. But if they've got advanced arthritis, arthroscopic surgery is just not going to help them, even if they're only 35 years old. And that's where what I tell people is that the issue isn't how much arthritis is too much arthritis for an arthroscopic approach. The issue is what's the reasoning? When does it stop being a preventative procedure? We need to do something sooner rather than later, protect your hip. and when is it a palliative procedure where the die is already cast, you know they're on that slippery slope of progressive arthritis, because as a palliative procedure, an arthroplasty is the best operation in all of orthopedics. And that's where, so on that age group, then oh, you're 35, you're too young for a hip replacement. Yeah, but when you're in the prime of your life, and if your hip is what keeps you from being able to play with your young kids and do things, that do you want to deprive yourself of the best operation in all orthopedics? And so, yeah, you'd rather live with your natural hip as long as possible, but if your quality of life is poor, you know, how long do you want to drag it around before somebody says, okay, now I'm old enough to get one? And I'm, you know, and I did do, and kind of dating back to the comments, I did do a total joint fellowship. So maybe the things that Dr. Andrews taught me, blending with some of the things I learned at New England Baptist in Boston doing total joints, may put me a little ahead of the curve on that. But beyond that, I don't do hip replacements. So for me to be commenting on that is kind of out of my area of expertise at present.
Okay, one last question we can answer and then we can wrap. What's the incidence of secondary development of lateral hip dysfunction or greater trochanteric pain syndrome post hip arthroscopy?
And I think that I can't tell you the exact incidence, but really that question applies not just it's associated with hip joint pathology, because we see people all the time with a joint problem and laterally based pain. Well, the hip will refer pain laterally sometimes. And that's where a diagnostic injection of anesthetic can help to identify that. But we see a lot of people, just as they're compensating for the hip, if their abductors aren't functioning well, they'll secondarily develop laterally based symptoms. And those are the sort of things where we'll inject the joint, get them on a rehab program for their abductors to get those stronger. Or sometimes they can have damage in the abductors as well as damage in the joint, and that's where the differential injections, where and especially in people over 55, if you did an MRI on everybody over the age of 55, most of them are going to show some abductor pathology and some problem in the joint, in trying to define, is this a joint problem and just coincidentally some laterally based symptoms, versus do they have substantial disease of both? And that's where those differential injections help us to kind of answer that question, because sometimes we will see people where arthroscopically will address the joint as well as the abductors, either with a formal repair of the abductors. We've got bioregenerative collagen patches, scaffolds we can lay over a partial tear to stimulate healing. So there's just tons of detective work that goes into that. I don't know if I answered the question they asked about the incident strictly.
No, I think you did. Yeah. No, I think you did. I think you did just fine.
Yeah, and I think if it didn't pre-exist with the right rehab, we have very little incidence of any true greater trochanteric pain syndrome. Maybe a little soreness, more sore than normal, but easily cleaned up.
Yeah. Well, Dr. Byrd, thank you so much. That's you like really helped us kick off this new format. I think you helped us hit one out of the park with this. So we appreciate your time so much, and hopefully you enjoyed your time, and I hope we can have you back sometime in the future.
Nobody asked me a single question about billing or
No, not at all.
So
not a single
that's
one.
That's why this is much more stimulating conversation than talking to a bunch of boring orthopedic surgeons.
Well, thank you, everyone. Again, reminder that CEU certificates will get out sometime in the next 24 hours from completion. If you guys need anything, you can always email me, and we will be back next month with another dynamic duo.
Yeah.
I think Savoy and Andre have confirmed.
That's what I said.
Good.
That's a dangerous duo right there.
Yeah, maybe Dr. Byrd will watch that one.
Let's have Dr. Byrd on the two.
Yeah.
And don't forget about OSET.
Oh yeah.
We're going to OSET. So I want to see everybody
in September.
Thanks for having me.
Thanks, guys. Have a great night.
Thank you. Thank you, Dr. Byrd.
Bye.
Thanks, Phil. Thanks, Ash.
Guys. Bye-bye.